Hello guys, welcome back, and in this video lecture we will talk about the retrovirus, that is RNA virus. Retrovirus, we have oncoviridae that causes the cancer. As the name suggests, onco means it causes cancer. So we have HTLV1 and 2, and then we have lentiviridae, which is the HIV. Then HIV1 and HIV2 comes under the lentiviridae family. And in India, HIV1 is more prevalent or more common as compared to HIV2. Now coming to HIV, HIV has got reverse transcriptase activity. The HIV, see, remember all the RNA viruses, first of all the RNA viruses are single-stranded RNA. This RNA is unsegmented, and we have one copy of this single-stranded RNA, one copy of unsegmented single-stranded RNA. But with the exception, we have retrovirus, and if you write retrovirus, then you can also write retrovirus. So instead of R, just write W. So in this, you can see that there are two copies of single-stranded RNA in case of HIV. So all the RNA are single-stranded RNA, but here in the retrovirus, the RNA has got two copies. Single-stranded RNA, but two copies in case of retro. Normally what we have studied in the general properties of virus that all the RNA viruses have got one copy of single-stranded unsegmented RNA. Here in case of HIV, it is unsegmented single-stranded RNA, but the exception is that we have two copies here. The size is 100 to 120 nanometer. And if you can recall reverse transcriptase activity where we have studied in a DNA virus, that is hepatitis B virus. All the hepatitis viruses are RNA except the hepatitis B, which is DNA particle. This is a DNA virus, and you remember in the P gene of this DNA virus, hepatitis B virus, we have studied that it has got a reverse transcriptase activity. In HIV also we have this reverse transcriptase activity. So reverse transcriptase activity is seen in both HIV as well as hepatitis B virus. Now coming to the serotype, I told you hepatitis 1, HIV 1 is more prevalent or more common in India as compared to HIV 2. So HIV 1 based on the envelope protein. You remember on the envelope we have the protein, and this envelope protein in HIV 1, based on that it can vary from M, N, O and P types. And then we have in the M type we have further 10 serotypes from A to K. So it will be HIV1, then we have M, then from M to K, again A to K, we have again 10 serotypes. For example, the most common serotype is serotype M. This is the most common, and then the 10 subtypes is serotype M. So remember, serotype M from these 10 subtypes. From this 10 subtypes, that is the serotype. M is the most common. I told you M is the most common. Then in some, what happens? There is circulating recombinant forms. That means in the same virus, we can have two serotypes. Example, there can be serotype M and can be serotype B or A. So two serotypes occurring in a same virus is known as circulating recombinant forms that can have more than one serotype together, and the most common being both A and E types together. So both A and E types are seen together, that is a circulating recombinant forms. See, I told you HIV1 group M subtype. Group M, in that we have again further, see, this is the HIV1M. Further in the M, we have 10 serotypes. So HIV1 group M, and then subtype from A to K. We have further subtypes from A to K. So subtype B is the most common worldwide. And subtype C, HIV1 group M. So this is HIV1 group M. In the group M, further we have from A to K. So this is the subtype or the serotype C is most common in India. Now coming to structure of HIV, I told you there are two copies of single-stranded RNA. So we have got two copies here of single-stranded RNA. You can see two copies of single-stranded RNA that is seen in case of HIV virus. Apart from that, we have got two types of genes. One are structural genes. Another one are non-structural genes. So structural genes are the genes that are going to form the structure. For example, the first structure is what? It is the envelope. So in the structural gene, first we have the envelope gene. The envelope gene is what? GP160 for HIV. Then we have GAGs, and then we have pol. So these are the three structural genes. What are the three structural genes? Envelope, GAG, and pol. Envelope is made up of GP160. If you further subdivide this GP160, somewhere roughly around it will be GP120 and GP41. See, this is a structural gene. So GP120 is the one that is present on the surface. So GP120 is the surface one, and GP41, see, it is through and through the membrane. This is the membrane, and this GP41 is going through and through the membrane. So GP41 is transmembrane GP. Transmembrane GP. Then what are the GP that are present in this envelope? So the envelope protein, what are the envelope protein? GP160, GP120 and GP41. Envelope protein is GP160. It is further subdivided into surface and transmembrane. Surface one is GP120 and the transmembrane one is GP41. Very easy. These are the envelope protein. Then we have structural, in that we have GAG. So GAG is very easy. P6, P7, P17 and P24. P6 is the budding protein. P7 GAG is the nucleocapsid. If you can see, P7 is the nucleocapsid. Here we have the nucleocapsid P7 GAG. Then P17 is the matrix. Is the matrix antigen. You can see this is the matrix antigen. The one blue color with the chain. This is the matrix antigen, which is P17 matrix. And then P24 is the P24. Very important. It is the core antigen, which is the capsid. So this is P24. So see, we have P6, which is budding protein, P6, P7, which is nucleocapsid, P17, which is matrix, this light blue color, then dark blue color, this one is the P24, which is the capsid, and most important one is capsid, which is P24 core antigen, guys. Very important, it is present in the core. This is core antigen P24, very important. Capsid it is, and it is most important for the needle stick injury. So remember, P24 we'll talk about when we talk about the needle stick injury. The third structural gene we have is the pol. So in the pol, again, we have three enzymes here. One is reverse transcriptase. So remember three enzymes as RIP, rest in peace, we know, right? So pol, someone strikes from the pole and dies, and remember from the pole it is rest in peace. So reverse transcriptase for RI integrase, and then we have RIP, P is protease. Reverse transcriptase, it is P66, P51. Then integrase, it is P32, and protease is P12. You need not to remember all these P's, just remember the capsid one, that is P24, and the envelope are P160, GP160, that is again GP120 and GP41. So again, let's talk about these things. The first one we have talked about the structural gene. In the HIV mature virion, we have envelope, GAG and pol. In the pol, we have rest in peace. So envelope is GP160. From GP160 on the surface it is, see, if this is the envelope, then the GP120 is on the surface, that is surface, and then within the membrane is the transmembrane, that is GP41. This is GP41, and then here is GP120. In the GAG, we have budding protein, that is P6. P7 is the nucleocapsid. Then the matrix is P17, and the core antigen here is capsid, which is P24. P24, guys, very important for needle stick injury. Then in the pol, rest in peace, R is reverse transcriptase. See, I told you, in two viruses we have reverse transcriptase. One is hepatitis B, that is a DNA virus. Another one, very important, is HIV that we are talking right now, reverse transcriptase. It is P66, P51. I is integrase, P32, and P is protease, P12. We'll talk all these functions one by one when we talk about the pathogenesis. This was the structural genes. Coming to non-structural genes, we have TAT, that is transcriptional transactivator. It speeds up the transcription process. So see, as the name suggests, transcriptional transactivator, that means it is going to activate the transcription. So it is going to speed up the transcription process. Then NEF is the negative factor gene. REV is the regulator, regulator of the virus. Regulator, RE of the virus. VIF is viral infectivity factor. VPU, VPX, very important. VPU in HIV is for unloading. VPX for exit, you can say, and it is the release of virion from the cell via the VPX. VPR, again, very important for the transport to the nucleus. So transport of this virion to the nucleus occurs via VPR. LTR is long terminal repeats. So we have LTR at the terminal, and this LTR helps in promotion and enhancer region. Now guys, coming to the pathogenesis. First of all, there is attachment. Attachment occurs with what? Attachment occurs with the help of envelope. See, we have an envelope of this virus, and with the help of this envelope, the attachment occurs. Now, attachment of this occurs by the envelope proteins, of course. What are the envelope proteins we have? It is GP160, that is the envelope protein. GP160, which is further on the surface, it is GP120. And on the transmembrane, it is GP41. So these envelope proteins are attached to CD4 cells. These are the CD4 cells that are going to get attached with this HIV virion. So this HIV virion gets attached to either the CD4 cells or to the macrophages, or there can be attachment to co-receptors. Co-receptors. These co-receptors are basically chemokine receptors. These are chemokine receptors. Chemokine receptors. So these chemokine receptors are further off co-receptor. That means we are talking about simultaneously binding with the two receptors. First one, chemokine receptor, is the R4 strain. So in the R4 strain, this CXCR4, see, if HIV binds to this CXCR4 receptor, it is known as HIV R4 strain. Then R5 strain we have is CCR5 receptor on the macrophages. This is on the CD4 cells. CD4 cells. That is why 4 is there in the end. So CXCR4 on the CD4 cell. CCR5 on the macrophage. On the macrophage. If HIV binds to, see, we are talking about binding of this HIV virion. This is a HIV virion. It binds to some cell in the body, in the human, to cause this HIV infection. So either it binds to CD4 cell, or it binds to macrophages, or it binds to the co-receptor. In the co-receptor, it is the chemokine receptors that it binds. HIV receptor can either bind to CD4 cell. That is why CD4 count is low in HIV. Then it can also bind to macrophages, or it can bind to chemokine receptors. In the chemokine receptor, we have two kind of strain. One is R4 strain, and another one is R5 strain. If the HIV binds to this R4, which is CXCR receptor that is present on the CD4 cell, if it binds to this receptor, it is known as HIV R4 strain. If HIV virion binds to CCR5 receptor, which is present on the macrophage, if HIV binds to this, then we call it HIV R5 strain of the virus. So this is the attachment. So basically, either it can get attached to CD4 cell, or it can get attached to macrophage, or it can get attached to both, which is CXCR4 on the CD4 cell and CCR5 on the macrophage. First step in the pathogenesis, guys, is attachment. Remember, the first step, this is a HIV virion. The first step, this is a CD4 cell. CD4 cell. Suppose the first step is binding or attachment of this HIV virion to the CD4 cell. Now what happens? This virus is pulled inside the cell, and this occurs with the help of endocytosis. Endocytosis means the virus is pulled inside the CD4 cell. Now what happens? Uncoating occurs. So the envelope proteins, capsid, everything is gone. What remains is only the nucleic acid. So which is our single stranded RNA. 2 copies of single stranded RNA, what we have in the HIV virus. So what we have, second step is the endocytosis. First step is attachment, second step is endocytosis, and the third step is uncoating occurs. Now that we have only the nucleic acid, that is single stranded RNA, it is converted to DNA with the help of reverse transcriptase. Here plays the role of reverse transcriptase. So reverse transcriptase is going to convert the single stranded RNA to the DNA. Now that we have got a viral DNA, this is transported into the nucleus. It goes into the nucleus with the help of what? Non-structural gene. Remember, transport from the cytoplasm to the nucleus occurs with the help of VPR. That is the transport non-structural gene. So VPR is going to take this DNA virus, and then it is going to take it into the nucleus. Once it is taken into the nucleus, then if this is the, suppose this one is the DNA of the HIV virus. This is the DNA of the human cell. Then it is going to integrate, or DNA of the virus, DNA of the human cell. Both of these integrate. And this integration occurs with the help of enzyme what? Integrase enzyme. And if you remember, grase enzyme, integrase. And if you remember the pole gene, we have RIP. First one is reverse transcriptase, that is going to convert this RNA into DNA. Second one is this integrase enzyme, that is going to integrate the viral DNA to the human DNA. So both are integrated, as the name suggests. Integrate means combined. Now that we have got a new DNA, then from this DNA transcription occurs. That means RNA is formed. And from this transcription, then the translation occurs. This is translation. From this, the protein synthesis occurs. This is translation. Now that we have new virion or new particle that is formed, it is released with the help of enzyme protease. Remember, in the pole gene, we have the third P, third enzyme, that is protease, and new virion is released. So these are the steps of pathogenesis. First, there is attachment. Either attachment to CD4 cell, macrophage cell, CCX4 that is present on the CD4 cell, CCR5 that is present on the macrophage. Then the second step is endocytosis. Endocytosis means the virus cell is, now this, if this is the HIV virus, it is pulled inside the CD4 cell with the help of endocytosis. Then in the HIV virus, all the capsid, nucleocapsid, all the things, all the envelope, everything is uncoating occurs. Now only the nucleic acid remains, goes inside the cell. Basically, first it goes into the cytoplasm. From there, DNA synthesized with the help of reverse transcriptase. See, this HIV virus is what? Single-stranded RNA. 2 copies of single-stranded RNA. From this, DNA synthesized with the help of reverse transcriptase. Now this DNA goes into the nucleus of the cell. It goes into the nucleus of the cell with the help of non-structural genes, which is PPR. Then with the human DNA, this viral DNA is integrated with the help of this integrase enzyme. Then the transcription occurs, that is RNA is formed. Then translation occurs, that is protein is formed. Now the new virion or the particle is released with the help of protease. So this is the pathogenesis of the HIV. How this HIV is transmitted, we know the sexual route. There is a sexual route. And let me tell you, blood transfusion is the most effective route. But why we say blood transfusion is not commonly seen? Because it is tested in the blood bank. When you give the blood transfusion, first it is tested by HIV, for HIV, for hepatitis, all these things are ruled out. That is why blood transfusion we do not most commonly see, but it is the most effective. Transmission is more than 90%. It is the most effective, but the incidence is decreased because in the blood bank we test for these hepatitis, HIV, and all these things. Sexual transmission is the one that is seen more commonly. In that, either it is a homosexual route, but unprotected vaginal intercourse, the incidence is 1 in 10,000. While for heterosexual, this is homosexual, guys. Homosexual means the homosexual, same sex. That means we are talking about anal intercourse. So homosexual is 1 in 30. So 1:30, that has got a high incidence. Heterosexual, well, on the other hand, that is vaginal intercourse, that is a heterosexual. The incidence is quite low as compared to the homosexual. Homosexual, the anal intercourse has got 1:30, while on the other hand, heterosexual, it is 1:10,000. So that is why we see more commonly seen in the homosexual people, HIV is transmitted. Another way of transmission is the needle stick injury. If by accidental, two ways, either by accident, you have pierced your skin with the HIV person needle. So needle stick injury can be seen in the healthcare worker. Incidence is 1:300. But needle sharing, for example, in case of IV drug abuser, we commonly see it is more prevalent. That is, the risk is high. That is 1:150. Then from, if you remember needle stick injury, what we have studied in needle stick injury is, needle stick injury, if you write it like blood stick injury, if you write it like blood stick injury, B for hepatitis B, stick is hepatitis C, and injury is HIV. For hepatitis B, the incidence is 30%. Transmission rate is, for hepatitis C, it is 3%. And for HIV, it is 0.3%. So HIV, needle stick injury, the incidence is 0.3% of the transmission. Mother to child, it is very high vertical transmission, and it is seen to get affected, the child get affected if the mother is HIV. Now let's talk about the CDC classification, guys. CDC classification, in the CDC, group A is the one wherein we are going to see the initial infection. The person will complain of common viral illnesses. The symptoms are shown as the common viral illness like fever, malaise. There is tiredness. The person will have weight loss or joint pain. All these things, aches and pains basically, are seen in the CDC group 1 individual. So initial, that is acute HIV syndrome, because acute HIV syndrome is generalized weakness, weight loss, all these things that are associated with other virus illness also. So what happens, there is roaming of the virus in the organs of the body that is seen. And then this virus goes and sits inside the lymphoid organs. Next is CDC group 2. In the CDC group 2, now the patient is not showing any symptom, and in fact patient are in denial mode. Even if you tell these patient that you are HIV positive, they won't accept it, because they'll tell that I'm not showing any symptoms, I don't have any problem, why should I start with antiretroviral drugs? Basically, why should I start with anti-HIV drugs? So patient are in denial mode. Reason behind is because the clinically this disease is latent for the CDC group 2 individuals. There is clinical latency, but mind this, that there is no microbiological latency. That means if you do the blood sample, if you do all the tests, they are going to come positive for HIV. Microbiologically, it is going to be HIV positive individual, but the clinically patient is going to be asymptomatic. There will not be any symptoms shown with the patient. Now what happens? The body is now trying to fight back. See, I told you, clinically there is going to be no symptom, but microbiologically these patients will start showing decrease in the CD4 count. Microbiologically they are going to show symptoms, so CD4 count now are going to get decreased. Here in group 1, the CD4 count is normal, but for group 2, CD4 count starts decreasing, but you can see a seroconversion. You know why? Because body is trying to fight back the HIV. So HIV copies are going to go down, while on the other hand CD4 count will start improving for a short period of span in this. Why? Because body is trying to fight back and make antibodies against this HIV, and HIV will be killed, and the HIV copies go down for quite some time when the body immunity is good. So this is seen in group 2. That is known as seroconversion. Now coming to CDC 3. Now group 3 patient, the symptoms start coming back again. So there is going to be generalized lymphadenopathy that is seen. Symptoms of the patient are seen now. So there is persistent generalized lymphadenopathy. How is this lymphadenopathy? There is going to be enlarged lymph node, but there are going to be more than 2 non-contiguous extra inguinal sites involvement. That means apart from the inguinal sites, there are going to be 2 non-continuous, 2 different sites, 2 sites at different location. There is going to be generalized lymphadenopathy. There is going to be lymph node enlargement of two lymph nodes, two sites that are separate, not continuous, or there can be this lymph node enlargement for more than 3 months is seen. Now coming to CDC group 4, the patient has progressed from HIV to AIDS here. Symptoms are going to get worsened, they are going to get progressed, and the patient will have opportunistic infections, patient can have cancer and even death. So now the patient has AIDS. How do we say the patient has AIDS? When the CD4 count is less than 200, then we say by definition that the person is now converted from HIV to AIDS. So group 4 CDC is AIDS related complex, or all the opportunistic infection. What are the opportunistic infections that we see? If the CD4 count is less than 5, the other infections that the person can have: tuberculosis, pneumonia, herpes zoster, oropharyngeal, candidiasis very important. Then non-typhoid salmonellosis, Kaposi sarcoma, very important. It is a sarcoma that occurs, Kaposi, second word is A, that occurs in the AIDS individual. And then NHL, non-Hodgkin lymphoma. So they can ask you a question like, most common opportunistic infection in the AIDS patient, guys, it is tuberculosis. Then most common fungal infection in the AIDS patient, it is candidiasis. They can ask most common non-Hodgkin lymphoma in the AIDS patient, it is DLBCL, which is diffused large B cell lymphoma. Now this lymphoma we have studied in Epstein-Barr virus, which is human herpes virus 4. They can ask most common space occupying tumor. This is CNS lymphoma. Basically, it is the diffused B cell lymphoma. Now, if the CD4 count is less than 200, then you can see involvement of pneumonia by xerocystis jirovecii, herpes simplex virus, herpes simplex ulcers, esophageal candidiasis, and all these things. So most important being xerocystis jirovecii and esophageal candidiasis. If it is CD4 count is less than 100, then the person can have all the diseases associated with the brain, like cerebral toxoplasmosis, cryptococcal meningitis, cryptosporidiosis, microsporidiosis, CMV cytomegalovirus, MAC, and progressive multifocal leukoencephalopathy. Then if the CD4 count is less than 50, then there are only 3 things, that is cytomegalovirus, CMV, MAC, and toxoplasmosis. If they ask most common glomerulonephritis in the HIV, it is focal segmental glomerulosclerosis, which is also known as HIV associated nephropathy, since there is a glomerulonephritis that is associated with the HIV patient. Most common hepatitis in the HIV, it is the most common hepatitis, that is hepatitis B. Most common skin symptom in the HIV, it is seborrheic dermatitis, and most common endocrine symptom is lipodystrophy. Now WHO says that, according to the WHO definition, when do we say the person is having AIDS? You remember I told you AIDS definition is when the CD4 count is less than 200 per millimeter cube. This is the CD4 count. CD4 count. If it is less than 200, we call that the person is having AIDS. But according to WHO says that definition is when you show 2 major symptoms and 1 minor symptom. So what are the 3 major symptoms? Among 3, if 2 are positive, that means weight loss of the person that is at least more than 10% of the body weight. Or if there is diarrhea for more than 1 month, we could say it chronic diarrhea. Or if the fever is more than 1 month, we say it prolonged fever or chronic fever. If among out of these 3, 2 are positive, at least 2 major signs plus 1 minor, we say the person is having AIDS. Then what are the minor signs? If there is cough for more than 1 month, that is going towards the TB patient, generalized pruritic dermatitis, skin condition, history of herpes zoster skin condition, oropharyngeal candidiasis we have discussed, and then chronic progressive disseminated herpes infection or generalized lymphadenopathy, PGL. Now, what if the patient is having, see, I told you most common opportunistic infection in the HIV is tuberculosis. If the patient comes to you with the TB, along with that you see that the person is having HIV also. How are you going to treat this patient? You first start with the TB. What happens if you start giving HIV treatment first? The immunity of the person will get better and the body will start creating a response to this TB and TB will be aggravated. That is why the first thing that we start is the anti-TB drugs, then we start with the HIV drugs. So first the patient we give anti-tubercular drugs and then we start giving antiretroviral drugs. What if the antiretroviral drugs are given first? Then the patient can go into immune reconstitutional inflammatory syndrome. That means immune reconstitution means if you reconstitute or make the immunity better, then there is going to be inflammatory response. See, I told you, if you give anti-HIV drugs first, the immunity will get better and then the body is going to fight more against TB and there will be inflammatory reaction, and this is known as immune reconstitution inflammatory syndromes. That means if you reconstitute, if you remake the immunity of the person, then it will show the inflammatory reaction. Now coming to lung infection in the HIV, we know that in the HIV patient, we can have a pneumonia. Pneumonia can be, or there can be pneumonia, or there can be tuberculosis. Pneumonia can be because of streptococcus pneumoniae. If the CD4 count is less than 500, this occurs. And the person can have TB, or there can be pneumonia because of the pneumocystis cerevisiae or pneumocystis carinii. So if the pneumonia is seen, CD4 count less than 500, TB is also seen if CD4 count is less than 500, and xerocystis cerevisiae or carinii, that is CD4 count less than 200 we see. So if the person is having pneumococcus, if you look at the radiological features, the streptococcus pneumoniae is going to show lobar pneumonia. That is, one entire lobe is consolidated. That is a lobar pneumonia. So lobe consolidation is seen. If you see a snowstorm appearance, then it is suggestive of TB. And if you see perihilar opacities, then it is suggestive of xerocystis cerevisiae or xerocystis carinii. So basically you need to combine both the CD4 count cell. That is, in case of pneumonia, CD4 count cell is less than 500. In TB also less than 500. For xerovisiae it is less than 200. But you need to see also the radiological features, what is showing in the radiograph, and then you can diagnose what kind of pneumonia the person is having, or what kind of disease the person, what kind of opportunistic infection the person is having. Then coming to diagnosis part, you can test the CD4 count cell and tell the person is having AIDS or HIV. Then the most sensitive test is ELISA. In the ELISA, we have 4 generations. So first generation, second generation, third generation. Nowadays, we do the 4th generation ELISA. In that, you remember the capsid, which is P24 antigen. We are going to detect the P24 antigen and the antibodies. So 4th generation ELISA is the one that we do, 4th generation enzyme immunoassay. So according to CDC guidelines, if ELISA comes, we test for HIV 1 and 2 both. If ELISA, that is a 4th generation ELISA, comes negative, that means the patient is not having either HIV 1 or HIV 2. If ELISA comes positive, that means either the patient is having HIV 1 or the patient is having HIV 2. Now, how do you differentiate both of these? If it comes negative, that means antibodies and P24 antigen is coming negative. That means the patient is not having HIV. But if it comes positive, it could be either HIV 1 or HIV 2. Now, to differentiate between both of these, what you do is differentiation immunoassay. So you do the differentiation immunoassay. But this also can come positive or negative. So how to confirm that the patient is HIV positive? For that, we are going to do the definitive diagnosis by nucleic acid testing. So in case if the patient you are having is doubtful diagnosis, say suppose if first you have done is ELISA. If ELISA comes positive, but if you want to see either it is HIV 1 or HIV 2, you do the differentiation immunoassay. Suppose if differentiation immunoassay comes negative. Now, what is it? Already we have seen in ELISA the patient is HIV positive, but here the differentiation immunoassay is coming negative. Then for that, you do the definitive diagnosis by the nucleic acid testing. For the doubtful cases, you can do the nucleic acid testing. For confirmation, you can do the Western blot, or you can do the RT-PCR. So even 40 copies can be detected with the help of this RT-PCR. RT-PCR is to know the number of copies. And for children, you can do the only PCR, normal PCR, not the RT-PCR, the normal DNA PCR. So what are the three confirmatory tests? Either you go for immunofluorescence assay, or you go for Western blot, and the third one is line or dot immunoassay. These are the three confirmatory tests. What are the three confirmatory tests? The first one is immunofluorescent assay. Second one is Western blot, and the third one is line or dot immunoassay. So immunofluorescent assay is, we see the fixed infected cells. Western blot, very important Western blot test, guys, very specific. There are nitrocellulose strips that are separated with the viral proteins. So we have different kind of viral proteins, and there is banding pattern to see if the person is infected. See, to detect the antibodies, how Western blot test is done to detect the antibodies in the patient, we keep a few antigens like here GP160, 120, GP41. These are the envelope proteins. ENV I'm gonna write, envelope proteins. Then we have GP17, GP24, GP6 and 7. They are not seen here, but they are the GAG one. GAG. So 6, 7, 17 is the matrix and P24 is the capsid. Then in the pole, reverse transcriptase, 66, remember reverse transcriptase. In the pole, we had mnemonic RIP, rest in peace. First one is reverse transcriptase, second is integrase, third is protease. Reverse transcriptase, remember P66 and P51. Then P66 and P51 is for reverse transcriptase. Then for integrase, we have P32. So P32 here is not seen, but P32 is for reverse integrase. And for protease, we have P12. So all these GPs are kept on a cellulose strip, nitrocellulose strip. So to detect the antibodies in a patient, we first keep few antigens, that is GPs. If the patient has antibodies against this, then the band will start forming. So you can see these bands. In the first, you can see these dark bands. So if there are so many bands, if you see so many bands, that means so many GP. That means there is a strong reaction. And if you see few bands, you can see only a few bands. That means there is a weak reaction, or the patient is showing weak positive for the Western blot. And if you see, this is the control, guys. If you see no band, there is no band, that means the patient is HIV negative here. So this is the Western blot technique. And WHO says there are two guidelines. One is WHO guideline, another one is CDC guideline. WHO says if the antibodies are against the two envelope bands, what are the three envelope bands? Either it is GP160 or GP120 or GP41. If among these three, if two comes positive, with or without the gag or pole bands. So if among these three, if two comes positive, then we say it is a positive Western blot. But CDC guideline says that presence of any two bands, three are enveloped, 160, 120 and GP, and one being P24. Remember, P24 is the capsid, which is a gag. P24 is a gag. So P24, very important. I told you, core antigen, very important. So among these four, if two comes positive, according to CDC, it is HIV positive in the Western blot test. The third one being line or dot immunoassay. Recombinant peptides or proteins are stripped on the membrane, and these are the types of the line or dot immunoassay. Now, suppose if a healthcare worker has come across a needle stick injury. If a person has come across a needle stick injury, now you need to detect yourself, either you have become HIV positive or not. You want to go for early detection. So tests that can be done following the needle stick injury. The first one to rise is HIV RNA. We know that P24 rises early, but even before P24 in the Western blot, you can see this HIV RNA, and then we have P24. So the first one to rise is HIV RNA, and the second to rise is P24 on the Western blot. So serology to check if the person has come across needle stick injury. You remember P24, I told you it is important for needle stick injury. So because P24 rises so early that you can see in a needle stick injury in the initial time if you have infected with HIV or not. So the first one to rise is actually HIV RNA and then P24. But if HIV RNA is not given in the option, then go for P24 antigen. On the Western blot, you can see positive. So guys, this is about HIV, the retrovirus. All the best.